So, hi again. A blessed day and wonderful day to all of you. So, this is the second topic of our um, health assessment lecture for this week. The second and the last topic of her lecture. So, before we move on with our discussion, let me again present to you this disclaimer slide. Alright, so this is the second and the last topic for this week. We will talk about the physical examination of the nervous system. So evaluation of the cranial nerves, the motor system, the sensory system, and the reflexes is the focus of this presentation. Keep in mind that the complex anatomy and physiology of the nervous system make our examination or physical examination and assessment especially challenging, but of course attainable with practice and dedication. These are the learning objectives of this presentation. At the end of the discussion, the student will be able to describe the structure and the function of the nervous system, obtain an accurate history of the neurologic system, identify the cranial nerves and the motor and the sensory function, perform screening neurologic examination, describe the use of the Glasgow Coma Scale in an unresponsive patient, and document the finding of the nervous system examination. And finally, of course, to be able to discuss or formulate a risk reduction and health promotion strategies to reduce strokes. Now, let us talk about the anatomy and physiology of the central nervous system. Your central nervous system composed of the brain, and the brain has four regions: the cerebrum, the diencephalon, the brain stem, and the cerebellum. Each cerebral hemisphere is subdivided into frontal, parietal, temporal, occipital lobes. It will be shown in the next slides. So this is the lateral view of the brain. Again, the central nervous system of the brain is a vast network of interconnecting nerve cells or neurons consisting of cell bodies and their axons. Single long fiber that conduct impulses to other parts of the nervous system. Again, the lateral view of the brain consists of this is the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe, the brain stem, and the cerebellum. So now let us look at the coronal section of the brain. So the brain tissue could be gray or white. The gray matter consists of aggregations of neuronal cell bodies. It rims the surfaces of the cerebral hemispheres, forming the cerebral cortex, while the white matter consists of the neuronal axons that are coated with myelin. So the myelin sheaths, which creates the white color, it allows nerve impulses to travel more rapidly. Deep in the brain lies an additional clusters of gray matter. This includes the basal ganglia, which affect movement, and the hypothalamus and the thalamus, which are the structures in the diencephalon. The thalamus processes sensory impulses and relays them to the cerebral cortex. Okay. On the other hand, the hypothalamus maintains homeostasis or balance and regulates temperature, heart rate, and blood pressure. The hypothalamus affects the endocrine system and governs emotional behavior such as anger and sexual drive. The hormone secreted in the hypothalamus acts directly on the pituitary gland. The internal capsule is a white matter structure where myelinated fibers converge from all parts of the cerebral cortex and descend into the brain stem. The brain stem, which connects the upper part of the brain with the spinal cord, has three sections. It has the midbrain, the pons, and the medulla. Consciousness depends on the interaction between the intact cerebral hemispheres and an important structure in the diencephalon and the upper brainstem, the reticular activating or arousal system. The cerebellum, which lies at the base of the brain, coordinates all movement and helps maintain the body upright in space. Now let's look at the spinal cord, particularly the cervical. Now, below the medulla or the central nervous system extends itself as elongated spinal cord encased with a bony vertebral column and terminating at the first or second lumbar vertebrae. So this cord provides a series of segmental relays with the periphery, serving as a conduit for information flow to and from the brain. Okay, so the motor and sensory nerve pathways relay neural signals that enter and exit the cord through the posterior and the anterior nerve roots, through the spinal and the peripheral nerves. Okay, the spinal cord is divided into 5 segments. It started with the cervical from C1 to C7 or 8, the thoracic from T1 to T12, the lumbar from L1 to L5, okay, and the sacral from S1 to S5, and the coccygeal. You can see it in the next slide, okay. So the cervical spinal cord contains nerve tracts to and from the upper and the lower extremities. And note that the spinal cord is not as long as the vertebral canals. Okay. So this is the image of the lumbar. Okay, the lumbar and the sacral roots travel the longest intraspinal distance and fan out like a horse tail at L1 from L1 to 2, giving a rise to the term cauda equina. To avoid injury to the spinal cord, most lumbar punctures are performed at L1 to L4 or L4 to 5 vertebral interspaces kapag kailangan kumuha ng mga specimen. Okay? Okay, so this image showed the whole picture of the spinal cord from C1 up to the coccyx, because in the previous slides we just divided it by part. So moving on to the peripheral nervous system. So the peripheral nervous system consists of the cranial nerves and the peripheral nerves that supply nerve stimulus to the heart, the visceral organs, skin, and the limbs. So your peripheral nervous system controls the somatic nervous system, which regulates muscle movements and responds to the sensations of touch and pain, and the autonomic nervous system that connects to internal organs and generates autonomic reflex response. The autonomic nervous system consists of sympathetic nervous system, which mobilize organs and their functions during times of stress and arousal, and the parasympathetic nervous system, which conserves energy and resources during time of rest and relaxation. There are 12 pairs of special nerves called cranial nerves that emerge from within the cranial vault, okay, through scalp foramina and canals to structures in the head and the neck. They are numbered sequentially with Roman numerals. We have cranial nerves 1 and 2, which are fiber tracts emerging from the brain. And the cranial nerves 3 through 12 arise from diencephalon and the brainstem, as illustrated here. Okay? So some cranial nerves are limited to general motor or sensory functions, whereas others are specialized and they have both a motor and sensory functions. The cranial nerves relevant to physical examination are summarized in the next slides. Okay, so this is just an image of the cranial nerves number 3, 4, and 7 that are involved in the activity of the eyes. Okay, so another example is the cranial nerve number 5, the trigeminal, that are involved for motor and sensory function. And the cranial nerve number 11, that is also responsible for the motor activity, particularly of the muscle. So this will be further discussed in the next slide. So these are the 12 cranial nerves, okay? Number 1, or the cranial nerve number 1, or known as olfactory, which function for the sense of smell, and the type of impulse is sensory. And then cranial nerve number 2, function niya is for vision, and the type of impulse is sensory. And then for oculomotor, or cranial nerve number 3, it function for pupillary constriction, opening of the eye, for example, lid elevation, and most of the extraocular or outside the eye movements. So this is motor, okay, yung kanyang type of impulse. And the cranial nerve number 4, or the trochlear, it is responsible for downward internal rotation of the eye. So its type of impulse is sensory. And then cranial nerve number 5, or known as the trigeminal. So its type of impulse is for motor and sensory, actually for both, no? So for motor, it is responsible for temporal and masseter muscles, or jaw clenching. and the lateral pterygoids or lateral jaw movement. And for sensory, it has function on the facial, no? The nerve has actually three divisions for ophthalmic, maxillary, and mandibular, so as shown in the previous slides. And then we have cranial nerve number 6, known as abducens. Okay, it functions for a lateral division of the eye, or its type of impulse is motor. Okay, cranial nerve number 7. Okay, so this has, or it has function for motor and sensory. So for motor, it is responsible for facial movements, including those of facial expression like closing of the eyes and closing the mouth. And for sensory, it is responsible for taste, particularly for salty, sweet, sour, and bitter substances of the anterior two-thirds of the tongue. And we have cranial nerve number 8, known as acoustic. Okay, this is responsible for hearing, okay, particularly the cochlear division, and it is responsible also for balance or vestibular division. So this is more of sensory. And we have cranial nerve number 9, glossopharyngeal. So glossopharyngeal has both function for motor and sensory. So for motor, it is responsible for the activity of the pharynx, and then for the sensory, it is responsible for the posterior portions of the eardrum and the ear canal, the pharynx, and the posterior tongue, including again the taste like salty, sweet, sour, bitter. Okay, we have cranial nerve number 10, known as the vagus nerve. Okay, so this has a function for motor and sensory. So for motor, it is involved with activity of the palate, the pharynx, and the larynx. And for sensory, it is responsible for the activity of the pharynx and larynx. Okay, cranial nerve number 11, or the spinal accessory. So, its type of impulse is more of motor, wherein the sternomastoid and the upper portion of the body, the trapezius, no, siya yung responsible. And cranial nerve number 12, known as the hypoglossal. So, its type of impulse is motor, or it is involved with activity of the tongue. Okay, so there are so many ways to remember the 12 cranial nerves. You can do a mnemonic, or you can use this riddle. Okay, O, 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 to touch and feel a girl's vagina. Ah, heaven. So O means for olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear. Okay. Yan lang yung naiiba, no? A. So, binaliktad lang yung B. Glossopharynx for girls, and then the vagus for vagina, and then accessories for A, and hypoglossal. Okay, this will help you remember the 12 cranial nerves. And another way to remember the 12 cranial nerves and its type of impulse. Okay, So we have here, some say marry money, but my brother says big brains matter more. So it starts with letter S, no, and letter M. So if it starts with letter S, it means its function is for sensory. Okay, for letter M, it's for motor, and for B, it's for both. So it's important that you memorize first the 12 cranial nerves using the technique in the previous slides, and then this slides is for you to remember its type of impulse, whether it's for sensory, motor, or both. Okay, so to continue with the anatomy and physiology, we have the peripheral nervous system. It includes the spinal and the peripheral nerves that carry impulses to and from the spinal cord. There are 31 pairs of nerves attached to the spinal cord. There are 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral, and 1 coccygeal. Each of these nerves has an anterior, okay, or ventral root containing the motor fibers, and the posterior or dorsal root containing the sensory fibers. The anterior and the posterior roots merge to form a short spinal nerve less than 5 mm long. The spinal nerve fibers mix with similar fibers from other levels in plexuses outside the cord, from which the peripheral nerves emerge. Most of the peripheral nerves contain both sensory afferent and the motor or efferent fiber. As mentioned in the previous slides, the spinal cord is like the brain that contains both the gray matter and the white matter. The gray matter consists of aggregation of nerve cell nuclei and dendrites that are surrounded by wide tracts of nerve fibers connecting the brain to the peripheral nervous system. You have to note this butterfly appearance of the gray matter nuclei with their anterior and their posterior horns. The motor pathways are complex avenues extending from the upper motor neurons through long white matter tracts to the synapses with lower motor neurons and into the periphery outside or outward regions through the peripheral nerves or nerve structure. The upper motor neurons of nerve cell bodies lie in the motor strip of the cerebral cortex and in several brain stem nuclei. So there are axon synapse with motor nuclei in the brain stem for cranial nerves and in the spinal cord for peripheral nerves. So the lower motor neurons have cell bodies in the spinal cord called anterior horn cells. Their axons transmit impulses through the anterior roots and spinal nerves into the peripheral nerves, terminating at the neuromuscular junction. There are 3 kinds of motor pathways impinged on the anterior horn cells: the corticospinal or pyramidal tract, that is responsible for controlling voluntary movement and integrates skilled, complicated, or delicate movements. So, another one is the basal ganglia system that maintain the muscle tone, control the body movements. On the other hand, number 3 is the cerebellar system that receives sensory and motor input, coordinates with motor activity. Okay, so all of these higher motor pathways, particularly those mentioned in the previous slides, affect movement only through the lower motor neuron system, sometimes called as the final common pathway. So any movement, whether initiated voluntarily in the cortex or automatically in the basal ganglia or reflexively in the sensory receptors, must ultimately be translated into action via the anterior horn or anterior horn cells. Any lesion of these areas will affect movement or reflex activity. When the corticospinal tract is damaged or destroyed, its function are reduced or lost below the level of injury. Okay, when the upper motor neuron system are damaged above the crossover of its tract in the medulla, motor impairment develops on the opposite or known as contralateral side. So in damage below the crossover, motor impairment occurs on the same or ipsilateral side of the body. The affected limb becomes weak or paralyzed, and skilled, complicated, or delicate movements are performed especially poorly when compared with large movements. So disease of the basal ganglia system or the cerebellar system does not cause paralysis but can be disabling. So damage to the basal ganglia system produces changes in the muscle tone, most often an increased disturbances in the posture and gait, a slowness or lack of spontaneous and automatic movements termed as bradykinesia, and various involuntary movements. Okay? The cerebellar damage naman or impairs, it can impair coordination, gait, and equilibrium, and it decreases muscle tone. Okay, so moving on to the sensory pathways. Sensory impulses participate not only in reflex activity as we mentioned in the previous slides, but also give rise to conscious sensation. It calibrates body position in space and help regulate internal autonomic functions like blood pressure, heart rate, and respiration. A complex system of sensory receptors relays impulses from the skin, mucous membranes, muscles, tendons, and viscera that travel through peripheral projections into the posterior root ganglia, where a second projection of the ganglia directs impulses centrally into the spinal cord. The sensory impulse then travels to the sensory cortex of the brain via one of two pathways. The spinothalamic tract, consisting of smaller sensory neurons with unmyelinated or thinly myelinated axons, and the posterior columns, which have larger neurons with heavily myelinated axons. When we say myelin, it is a mixture of proteins and phospholipids which form a sheath around the nerve fibers, and it increases the conduction of the nerve impulses. The peripheral component of the small fiber spinothalamic tract arises in free nerve endings in the skin that register pain, temperature, and crude touch. With one or two spinal segments from their entry into the cord, these fibers pass into the posterior horn and synapse with secondary sensory neurons. The secondary neurons then cross to the opposite side and pass upward into the thalamus. In the posterior column system, The peripheral large fiber projection of the dorsal root ganglia transmit the sensation of the vibration, proprioception, kinesthesia, pressure, and the fine touch from the skin and joint position receptors to the dorsal root ganglia, where they travel through the central projection in the posterior columns, second-order sensory neurons in the medulla. The fibers projecting from secondary neurons cross to the opposite side of the medullary level and continue on the thalamus. When we say proprioception, it refers to a sense of position of the parts of the body and strength necessary to move. When we say kinesthesia, it refers or it means to movement sense. Remember that those patients with diabetes with small fiber neuropathy usually report sharp, burning, or shooting foot pain, whereas those with large fiber neuropathy experience numbness and tingling or even no sensation. Okay, so remember that lesions at the different points in the sensory pathway produce or could produce different kinds of sensory loss. So the patterns of sensory loss together with their associated motor findings help identify where the lesion might be that are causing the loss. For example, a lesion in the sensory cortex may impair the perception of pain, touch, and position, for example, but does not impair finer discrimination. Okay, so this image shows dermatomes innervated by posterior roots. Okay, a dermatome is a band of skin innervated or receiving nerve impulse by the sensory root of a single spinal nerve. So, knowledge and testing of dermatomes help us identify which spinal cord segment has the lesion. Okay, it looks like a map, no, yung dermatome. Moving on to spinal reflexes, or the muscle stretch reflex and the deep tendon reflex. So when we say reflex, it refers to involuntary stereotypical response. To check is by firstly tap the tendon of a particular stretch muscle. The stopping tendon activates special sensory fibers, and then each deep tendon involves specific spinal segments that can help you locate a pathologic lesion. Okay, so the deep tendon reflex or Golgi reflex is a polysynaptic and relays information from sensory neuron to a motor neuron across two or more synapses, including muscle relaxation, lengthening, and response to increased tension in the muscle. The reflex controls muscle tension through relaxation so that the muscle force or contraction does not become so strong that the tendon is torn. Okay. For the reflex to fire, all components of the reflex arc must be intact. Sensory nerve fibers, spinal cord synapse, and motor nerve fibers, neuromuscular junction, and the muscle fibers. So tapping activates special sensory fibers in the particularly or in the partially stretched muscle or tendons, triggering a sensory impulse that travels to the spinal cord via a peripheral nerve. Okay, the stimulated sensory fiber synapses directly with the anterior horn cell innervating the same muscle. So when the impulse crosses the neuromuscular junction, the muscle suddenly contracts, completing the reflex arc. Because each deep tendon reflex involves specific spinal segments together with their sensory and motor fibers, an abnormal reflex can help locate a pathologic lesion. Okay, so you have to learn the segmental levels of the deep tendon reflex. They can be remembered by their numerical sequence in ascending order from the ankle to the triceps. Okay, here no. So for the ankle reflex, okay, the sacral one primarily yung for the knee reflex or patellar. So the spinal is the lumbar 2, 3, and 4. For supinator or brachioradialis reflex, it's in the cervical 5 and 6. Same with the biceps reflex. While triceps reflex, ang involved is the cervical 6 and 7. So, reflexes may be initiated by stimulating skin as well as the muscle. So, stroking the skin of the abdomen, for example, could produce a localized muscular twitch. Okay, superficial cutaneous reflexes and their corresponding spinal segments include the following. For the abdominal reflex, upper. So involved is the thoracic 8, 9, and 10. For abdominal reflexes lower, the involved spinal cord is the thoracic 10, 11, and 12. For the cremasteric reflex, it involved the lumbar 1 and 2, while the plantar responses, lumbar 5, and sacral 1. For the anal reflex, the sacral 2, 3, and 4. Now moving on to the health history. So, the following are the common or concerning symptoms: the headache, injury, dizziness or vertigo, generalized proximal or distal weakness, numbness, abnormal or loss of sensation, syncope or near syncopes, seizures, tremors, or involuntary movements. Two of the most common symptoms in neurologic disorders are headache and dizziness. So if there is headache, of course you have to review the health history pertaining to headaches. So headaches may have many causes ranging from benign to life-threatening. Therefore, when there is a complaint of headache, there's always a warrant a thorough assessment. So, neurologic causes such as subarachnoid hemorrhage, meningitis, or muscle lesions are very important. Now, pay close attention to the headache history and your examination findings. So, there are different kinds of headache. We have a primary headache that include migraine, tension, cluster, and trigeminal autonomic cephalgia. Secondary headache arise from underlying structural, systemic, or infectious causes and may be life-threatening. So, you have to assess or you have to use your old card in assessing for the headache, the onset, location, okay, duration, severity, okay, by asking the client using the pain scale, associated symptoms, visual changes, weakness, loss of sensation, affected by other symptoms like coughing, sneezing, or sudden movement of the head. Okay, so if there is presence of dizziness or vertigo or lightheadedness, which are common yet vague complaints that could have many meanings, you will need to elicit the patient's experience through a specific history and neurologic examination. You can also use your old card. For patient complaints with weakness, okay, you can also check for the following. No? Is it generalized or localized? Is the patient unable to move? Is it from the proximal or distal? Okay, these are just examples. Remember that weakness is another common symptom with, again, many causes that bears careful investigation. So therefore, it is important to clarify what the patient means by weakness, fatigue, apathy, drowsiness, or actual loss of strength. Okay, so you also check if there is change or loss of sensation, particularly for those patients who report numbness. Okay, so you have to ask the patient to be more precise. You can ask if there tingling like pins and needles, which are altered sensation caused by paresthesia. Okay, so you can also um, ask if there is difficulty moving, okay, and so on. Okay. Some patients may report of fainting or passing out or blacking out, or what we call near syncope or syncope, that are actually common, and of course it warrants a meticulous history to guide management and a possible hospital admission kung kinakailangan. So you can begin by finding out whether the patient has experienced syncope or near syncope. When we say syncope, the patient has actually lost consciousness and postural tone from transient global hypoperfusion of the brain, while in near syncope, the patient feels lightheaded or weak but fails to actually lose consciousness. So therefore, true syncope is more serious symptom. So you have to get complete and unbiased description of the event, no? As possible. Okay, you can check if the patient can still hear your voice, particularly for those merong true syncope. Another part of your health history is to check if there is seizures. When we say seizure, it is a paroxysmal disorder that are caused by sudden excessive electrical discharge in the cerebral cortex or its underlying structures. So seizures can be or can have different types depending on the type. There may or may not be loss of consciousness. With some type of seizures, there may be abnormal feeling before the seizures, um, thought process, and sensations, including smells, as well as abnormal movements, asking, have you ever had any seizures or spells, and any fits or convulsions can actually open the discussion. So the common causes of acute symptomatic seizures include epilepsy, head trauma, alcohol, cocaine, drugs, withdrawal from alcohol, and etc. Okay, so you can also ask, no, if How long do they last if they're experiencing as a short for how many minutes? How frequent? Or is there any changes in frequency? Is there any history of head injury? And what are you doing to treat your seizure? Okay, so another focus of the health history is the tremors and other involuntary movements that occur with or without other neurologic manifestations. You can ask the patient about trembling, shaking, uncontrollable body movements, and leg restlessness. Okay, so this slide shows some tremors and involuntary movements. So we have here resting or static tremors that are most prominent at rest and may decrease or disappear with voluntary movement. So this is common, okay, relatively slow, fine, pill rolling tremor of Parkinsonism. So another one here is the postural tremors. These tremors appears when the affected part is actively maintaining a posture. For example, it includes the fine rapid tremor of hyperthyroidism. Okay, the tremors of anxiety and fatigue and benign is essential and sometimes a familial tremor lang. So another one here is the intention tremor. This is usually absent at rest, appear with activity, and often get worse as the target is neared. Okay. Causes include disorders of cerebellar pathways, as in those who have multiple sclerosis. So another involuntary movement here, we have the oral facial dyskinesias. Okay, these are rhythmic, repetitive, bizarre movements that chiefly involve the face, the mouth, the jaw, and the tongue. So grimacing, pursing of the lips, protrusions of the tongue, and opening and closing of the mouth and deviation of the jaw. So these movements may be a late complication of psychotropic drugs such as phenothiazines. See? So this will also occur in long-standing psychosis in some elderly individuals and in some edentulous persons or those persons without teeth. So another involuntary movement we have here the tics that are usually brief, repetitive, or stereotype coordinated movements occurring at irregular intervals. Examples include repetitive winking, no? Kala mo kinikindatan ka, kala mo crush ka, so mayroon lang pala abnormality. Okay, grimacing and shoulder shrugging. Okay, another one is dystonia. They are actually similar to athetoid movements but often involve larger portions of the body including the trunk. Yan. Okay, so another abnormality or tremors and involuntary movements, we have here the athetosis or athetoid movements that are slower and more twisting and writhing than choreiform movements and have larger amplitude. They most commonly involve the face and the distal extremities. Causes includes cerebral palsy. So we have here the chorea or choreiform movement, which are brief, rapid, jerking, and irregular and unpredictable. They usually occur at rest or interrupted normal coordinated movement. So it's unlike tics, they seldom repeat themselves. So the face, the head, the lower arms and hands are often involved. So causes includes Sydenham chorea with rheumatic fever and Huntington disease. Now let's move on to physical examination. Okay, for the cranial nerve examination, you will need to prepare the following materials: the pen light, Snellen chart, newspaper or handheld newspaper, ophthalmoscope, cotton swab, tongue blades, gloves, sets for olfactory like vanilla, cinnamon, coffee, lemon juice, or soap, and tuning fork. Okay, so for the examination of the sensory, you will need the following equipments or materials: objects to feel like coin, paper clip, tuning fork, hot and cold water in test tubes or glass, cotton swabs. For the examination of the muscle stretch response or the deep tendon reflex, you will need your reflex hammer and tongue blade. Okay, so these are the important areas of examination. So the mental status, cranial nerves 1 through 12, motor system such as for coordination, gait, stance, sensory system for pain and temperature, position and vibration, light touch and discrimination. Also for the deep tendon, abdominal and plantar reflexes. So integrate neurologic assessment with other parts of the examination, such as the mental status and speech during the interview, some cranial nerves with head and neck. So if you're doing the assessment of the head and the neck, inspect the arms and legs for neurologic abnormalities while observing peripheral vascular and musculoskeletal system. So this just means that yung cranial nerves naman natin, pwede natin siyang isama to check when you are doing your physical examination 1, di ba? When we are doing the examination of the head and the neck. And then think about and describe your findings in terms of nervous system as a unit. Okay, so these are the guidelines for screening neurologic examination from the American Academy of Neurology. You have to start from the mental status and then the cranial nerves, such as the visual acuity, pupillary light reflex, the eye movement, the hearing, the visual strength. For the motor system, you have to check for the strength, the gait, and coordination. Then sensory for light touch, pain, temperature, proprioception, and reflexes for the deep tendon reflexes and plantar responses. So now let's start with the cranial nerves. For cranial nerve number 1 or the olfactory, you can use familiar and non-irritating odors. And then you can ask the client to close one nostril and sniff. Test other side. Ask the patient to identify the odor with the eyes closed and avoid nauseous triggers that might stimulate cranial nerve number 5. Now you can inspect the optic fundi with a ophthalmoscope, paying attention to the optic disc. Inspect each disc carefully for bulging and blurred margins, or what we know as papilla edema, for pallor or optic atrophy, and cup enlargement for glaucoma. Okay, So inspect the size and the shape of the pupils and compare one side with the other. Okay, this was mentioned in the previous lectures natin. Okay, you have to check for optic and oculomotor, the size and the shape of the pupils. It should be symmetrical, diba? Or baka merong anisocoria, okay, wherein the pupil is not symmetrical, or there is a difference of greater than 0.2 millimeter in diameter of one pupil compared to the other. Okay, the reaction of the pupil to light. Also check for the near response of accommodation, like what we did in your physical examination 1. Okay, for the pupillary reactions, or yung ginawa natin sa physical exam 1, wherein you have to check you have to ask the client to look at the object. Okay, when the object is near, the pupil constrict. When the object is at far, the pupil dilate. No, same with the reactions to light. No, if there is light, the pupil constrict, and in the dark room, the pupil dilate. Okay, to continue, in the physical examination of cranial nerve, number 3, uh, 4, and 6, which are your oculomotor, trochlear, and abducens. Okay, you have to check for the extraocular movements in the 6 cardinal directions, or directions of gaze, and you have to look for loss of conjugate movements in any of the 6 directions, which causes diplopia. You can ask the patient which direction makes the diplopia worse, and then inspect the eye closely for asymmetric deviation of the movement. Okay, so check for convergence of the eye, identify any nystagmus and involuntary jerking movement of the eyes with quick and slow components. Okay, you have to check also if there is double vision. Okay, so nystagmus may be present in all directions of gaze, but it may appear or become accentuated only in one division of the eye. For an example, to the side upward. Okay, on extreme lateral gaze, the normal person may show a few bits resembling nystagmus, and observe nystagmus only within the field of full binocular vision. So for the direction of the quick and slow components, example, no, left beating nystagmus, or there's a quick jerk, okay, to the left in each eye, then a slow drift to the right. So nystagmus usually has both slow and fast movements, but is defined by its fast phase. For example, if the eyes jerk quickly to the patient's left and drift back slowly to the right. Okay. The patient is said to have left beating nystagmus. So, okay, for the cranial nerve number 5, or the trigeminal nerve, okay, you can do this by palpating the temporal and then the masseter muscle. You can ask the patient to clench the teeth, and then you note the strength of the muscle contraction. You can ask the patient to move the jaw to side to side. So if there is difficulty clenching the jaw or moving it to the opposite side, in masseter and lateral pterygoid muscle weakness. So if there is jaw deviation during opening, points to weakness on the deviating side. So you have to look for unilateral weakness in cranial nerve number 5. This could be a sign of lesions in the pons. If there is bilateral weakness in cerebral hemispheric disease because of bilateral cortical innervation. So again, your trigeminal has also a sensory function that is tested on the forehead, the cheeks, and the chin, each side for pain, sensation. Okay, so you have to instruct the client to close the eyes during the actual test. However, prior to the examination, demonstrate what sharp and dull each feels like. So, dapat alam mo na ni patient. And then you can use appropriate sharp object such as a sharp wood or sharp wood splinter by breaking or twisting a cotton swab or tongue depressor for the sharp sensation, and the use end of the cotton swab as a dull stimulus. And then you can ask the patient to report whether it is sharp or dull and to compare the sides. Or you can also use temperature sensation. Okay, particularly if you detect a sensory loss. Okay, you can confirm it by testing the temperature. You can use 2 test tube filled with hot and ice cold water. Okay, which is actually traditional, or a tuning fork may also be used. If it usually feels cool, okay, if you are near the running water, the fork is easily made colder or warm. Try it before use, of course, baka too hot or too cold. Then you can test the light touch using a fine wisp of cotton and ask the patient to respond whether you touch the skin. That is for the light touch. Okay. Now, to continue with our testing the trigeminal, you can also test the trigeminal nerve by corneal reflex. You can ask the patient to look up and away from you and approach from the opposite side out of the patient's line of vision, avoiding the eyelashes. Lightly touch the cornea, not just the conjunctiva, with a fine wisp of cotton. If the patient is apprehensive, touching the conjunctiva first may be helpful. And then you assess for blinking of the eyes, the normal reaction to the stimulus. Diba? Once na tinusok mo yung, or hindi mo naman tutusukin, or you put something on the eyes, diba? Talagang may reaction. Okay, so moving on to the physical examination of cranial nerve number 7, the facial. Okay, you can do this by inspecting the face of the client at rest and during conversation with the patient. Note any asymmetry. Example, there is asymmetrical nasolabial folds, and observe for tics or other abnormal movements. Okay, you can also ask the patient to raise the eyebrows, to frown, to smile, and etc. Okay, you can also ask the patient to close both eyes to test for muscular strength like what you see in this picture. So habang kino-close ni patient, okay, yung eyes, you are also opening the eyes of the client. So that is to test for the muscular strength. And you can show both upper and ask the client to show both upper and the lower teeth, to smile, and to puff out cheeks. That is to check if there is symmetrical movement. If there is flattening of the nasolabial fold and drooping of the lower eyelid, that suggests a facial weakness. Okay. Facial weakness or paralysis may result either number 1 from peripheral lesion of cranial nerve number 7, the facial nerve, or anywhere from its origin in the pons to its periphery in the face, or from a central lesion involving the upper motor neuron system between the cortex and the pons. Okay. This is just an example of abnormality of the face. Okay, so for the central lesion, the lower part of the face normally is controlled by upper motor neurons located on only one side of the cortex, the opposite side. Left-sided damage to these pathways, as in stroke, paralyzes the right lower face. The upper face, however, is controlled by pathways from both sides of the cortex. Even though the upper motor neurons on the left are destroyed, others on the right remain, and the right upper face continues to function fairly well. So, to assess for cranial nerve number 8, the acoustic, okay? You can assess this by assessing the hearing with the whispered voice, okay? And you can ask the patient to repeat numbers that you whispered into one ear while blocking or rubbing your fingers or the patient fingers next to the contralateral ear. If hearing is lost, determine if the loss is conductive from impaired air-through-air transmission, or is it sensory neural from damage to the cochlear branch of the cranial nerve number 8. You have to test for air in the bone conduction using the Rennes test, as what you have performed during physical exam 1, and lateralization using the Weber's test. Okay, so to test for cranial nerve number 9 and 10, the glossopharyngeal and vagus nerve, you listen to the patient's voice. Is it hoarse or does it have a nasal quality? So hoarseness in vocal cord paralysis and nasal voice in paralysis of the palate. Is there difficulty swallowing? Okay. Difficulty swallowing could suggest pharyngeal or palatal weakness. Ask the patient to say ah or to yawn as you watch the movements of the soft palate in the pharynx. The soft palate normally rises symmetrically. The uvula remains in the midline and each side of the posterior pharynx moves medially, like a curtain. Okay, to test for cranial nerve number 11, the spinal accessory. Look for atrophy or fasciculations in the trapezius muscles and compare one side with the other when standing behind the patient. Fasciculations are the flickering irregular movement in small groups of muscle, okay, or muscle fibers. You can ask the patient to shrug both shoulders upward against your hands, and then you have to note the strength and contraction of the trapezius muscle. So if there is a trapezius weakness with atrophy and fasciculation, this could indicate a peripheral nerve disorder. In trapezius muscle paralysis, the shoulder usually droops and the scapula is displaced downward and laterally. So you can also ask the patient to turn to each side against your hands, and then you observe like what you can see in this picture, and then you can observe the contraction of the opposite sternomastoid, and you have to note the force of the movement against your hands. Okay, so that ends the first part of the physical examination of the nervous system. So there is another video, the part 2 or the continuation of this presentation. So for now, this is the reference. And again, let me share to you this quotes. Nurse, just another word to describe a person strong enough to tolerate everything and soft enough to understand everyone. So I hope that would be you. Thank you, everyone. Please watch the second part of this presentation.